I really do believe that there is an important place for drugs in myeloproliferative neoplasm. However, we really do need to get back to the basics in terms of really focusing on our health with exercise and with diet. And small changes that we make in our lifestyles could reap us big benefits in the long run for whatever condition one may have, including myeloproliferative neoplasms. So a brief outline of what I'll be talking about today. Question of what is inflammation? We talk about inflammation all the time, but what actually is it? Number two, why is inflammation important in MPN? What could potentially, or what are many things that can be driving inflammation in MPN? And then thirdly, which is an open question, is what can we do to reduce inflammation in MPN? And I'll be focusing in that part on the beginnings of some studies looking at diet. So what is inflammation? We all sort of have an idea of what inflammation is: aches and pains in our bodies, things being hot, swollen, red. But why do our bodies create inflammation? So inflammation is really important for fighting an infection. If we have a bacteria in our body, we need to mount a response to it and kill the bacteria. So in some cases, inflammation is very good because it's helping us fight invaders. However, once that invasion is gone, you want to stop the inflammation when it's not helpful to you anymore, and then that can be bad. And in many times in autoimmune diseases, our bodies are inappropriately thinking that we're being invaded and trying to mount a response to get rid of an invader that isn't necessarily there. We talk about these words called cytokines, which can also be thought more commonly as you can just talk about inflammatory proteins. That might be a more commonplace way to talk about these proteins. And our bodies make these inflammatory cytokines or proteins in response to different stimulus. There are different cytokines that are involved in increasing inflammation. Other cytokines can be also important for dampening down inflammation. And in this slide, what I did is put together from different studies inflammatory proteins that have been found to be elevated in MPN patients, as well as in mouse models of MPN. And one of the inflammatory proteins that we're very interested in is called TNF. It's a very common inflammatory protein and is the target of many treatments for autoimmune diseases target trying to get rid of TNF alpha. And why is inflammation high in MPN? Well, that's a good question. We know that JAK-STAT signaling is important, is downstream of cytokine receptors, and JAK-STAT signaling is important for cytokine signaling. Also, interestingly, that JAK2 mutant cells not only increase inflammation production on themselves, but can create an environment which then makes their normal cells in the same environment overproduce inflammatory proteins as well. So they create a pro-inflammatory environment. Also, another question is, could high inflammation predate MPN? We know that MPN increases inflammation, but could inflammation also predate the acquisition of an MPN and create an environment that is conducive to the development of an MPN? That's a key area of research that my lab is working on. I won't necessarily go through that data today. We'll be focusing mostly on diet. But that's something that's very interesting to me. Interestingly, autoimmune diseases, which are inflammatory diseases, are more frequent in patients with a myeloproliferative neoplasm. So that inflammatory diseases and MPNs really do travel together. So this is a picture of what JAK2's role in normal blood cell production is. So JAK2 is a really important signaling protein for blood cell development. And it helps our bodies know when we're supposed to be making more red blood cells. So our bodies, as well as platelets, as well as white blood cells, our bodies need a way to know how to keep our blood cells under homeostasis. So for example, if you lose blood, you need to make the blood again. So we have cytokines, which also, for example, erythropoietin or EPO and thrombopoietin or TPO, which then bind to cytokine receptors. The cytokine receptor units come together, which makes them, quote, activated. Then a wild type or normal JAK2 will be activated and give a signal to the cell to say, hey, you need to make red blood cells or platelets. But what happens with a JAK2 V617F mutation is that the JAK2 protein is always active, such that the cells are thinking that they're always getting the hormone to produce more blood cells. Interestingly, that calreticulin and MPL mutations, although they're in totally different genes, do basically the same thing. A calreticulin mutation actually binds to the outside of the cell where those two things are sticking up and binds to it and then leads to activation. And then MPL mutations are mutations in the receptor itself. So although MPN patients may have 3 different mutations, the end result is always the same. They lead to activation of signaling pathways that are basically turning on blood cell production, as well as can turn on inflammatory protein production. And then this side shows that there are lots of different receptors, lots of different JAK proteins, and each sort of has a slightly different end result, but in general, they lead to cell proliferation and production of inflammatory proteins. And interestingly, specific cytokines or specific inflammatory proteins drive specific symptoms in MPN. So interestingly, some MPN patients may have predominantly one type of symptom, another MPN patient may have predominantly a different type of symptom, which may be from multiple different sources. However, one could potentially think that your unique compilation of symptoms may be a consequence of what specific cytokines are elevated in you. Also, chronic inflammation has important implications for blood stem cells. We know in particular from mouse models where we can induce chronic inflammation and see what happens to the blood stem cells, is that the blood stem cells, what we say, exhaust, or they basically poop out if we give the mice chronic inflammation. And what's really interesting, and a common feature that's emerging among mutations that are seen in myeloproliferative neoplasms and other chronic blood conditions, that these mutations make the blood stem cells resistant to the negative consequences of chronic inflammation. So one could envision a scenario where you're getting lots of inflammation, your normal stem cells are really pooping out, and then what's obviously going to be left are stem cells which have mutations which make them resistant. So they're able to survive in that inflammatory environment. And that's why, interestingly, as normal humans age, even without any blood conditions, we can detect these mutant cells in their blood. And it's also important to sort of look at our current therapies that we have for MPN, and interestingly, a lot of them are impacting inflammation. Aspirin, almost all MPN patients take aspirin, and the primary purpose is to help prevent blood clots. But aspirin also has anti-inflammatory properties, which is interesting. Potentially, maybe another benefit of aspirin is to reduce inflammation. And then the interferon and JAK inhibitors are a little bit of a counterintuitive combo here. That on one hand, we have JAK inhibitors which block JAK STAT signaling pathways and block inflammation. And then we have interferon, which is really interesting that interferon is a cytokine, an inflammatory cytokine, and actually can activate JAK-STAT signaling. So we've got treatments on two totally ends of the spectrum with regards to inflammatory signaling. Whereas in JAK inhibitors, sort of ironically, the JAK inhibitors don't get rid of JAK mutant cells. However, interferons, which actually are a JAK activator, do. So it's a scenario that is really unclear exactly how interferons necessarily work, and a little bit of I think that's an important concept to capture, that interferons are actually JAK. They actually activate JAK signaling. How can we control inflammation? So JAK inhibitors are anti-inflammatories. Other JAK inhibitors are used for autoimmune diseases, not specifically the ones that we just use different ones in different diseases just because they've been developed in different diseases. I also fully believe that it's very important to maintain a healthy weight because fat tissue can increase inflammation. Maintaining a healthy weight is good for anyone, not just MPN patients, as well as a healthy lifestyle that I'm not sure whether, I think it is important to classify MPNs as a cancer because people do have a mutation. However, it sometimes may be doing people a disservice that they may have a change in their attitude such that maybe are underappreciating the impact of lifestyle interventions, and so potentially may be more appropriate to view a myeloproliferative neoplasm more as a chronic disease, such as diabetes or hypertension or high cholesterol, in which those diseases we really understand that the things that somebody can do for themselves in terms of diet, exercise, weight loss are really important. So wanted to look at ways that MPN patients, we could offer patients approaches that are low risk, low cost, and really allow patients to regain control of their treatment of their disease. And can also manage symptoms, and potentially and ideally what we would like to do is prevent disease progression. So we were thinking about diet. And thinking about what type of diets would be most appropriate for the MPN patient population to reduce inflammation. So we turned to the Mediterranean diet, which in large studies in patients with cardiovascular disease have been found to improve outcomes and to reduce markers of inflammation such as high-sensitivity CRP and IL-6. And the key properties of a Mediterranean diet are high fiber. There's also a body of literature in terms of high fiber diets and reducing inflammation. Also rich in anti-inflammatory compounds, and also importantly, the fats are coming from monounsaturated fats. And so our central hypothesis was that if by following a Mediterranean diet, MPN patients might be able to reduce inflammatory cytokines, and this would improve symptom burden and also potentially blunt the disease trajectory. So we've performed thus far two very early stage studies of diet in patients with myeloproliferative neoplasms. And I'm glad that Dr. Michaels gave us a really nice presentation this morning in terms of the different stages of a clinical trial. And wanted to highlight that in order to really investigate the impact of something, one needs to start at bottom in terms of really establishing whether people can actually do the intervention, the safety of the intervention. So I want to be clear on in terms of what our purposes with these first studies were. The initial pilot study, we chose to compare a Mediterranean diet versus the standard USDA guidelines for Americans. And our purpose was basically to ask if we give MPN patients in-person, one-on-one dietitian counseling, are they able to change their diet? We also, as an extra, wanted to observe things like their blood counts, their inflammatory proteins, and their the gut microbiome. However, the purpose for looking at that was simply to gather data, not necessarily to make any claims. And then our second diet, we did what we call an e-intervention, wanted to ask the feasibility of doing Zoom-based counseling sessions for our dietitian counseling. And because it was a remote study and weren't able to draw blood from patients, how could we obtain biological samples from these patients with oral measures of inflammatory cytokines? So this is the schema of our initial diet study. It was a 15-week study. For 2 weeks, we just wanted to observe people in their natural state, not telling them to do anything other than we wanted to ask them what they were eating, how they were feeling, and wanted to get some biological samples of blood and stool. And then people had a 10-week course of one-on-one dietitian counseling, which included 3 sessions. Also mirrored after the large Mediterranean diet study, we gave people olive oil who were in the Mediterranean diet group, and then a gift card for a grocery store if they were in the standard diet. Also during that time point, we continually asked them about their symptoms, also what they were eating, and took stool samples and blood samples. And as I mentioned, the main point of this study was that wanted to ask if MPN patients can change their diet with dietitian counseling, and also we gave written curriculum. And to quantify this, we used what's called the MEDAS score, the Mediterranean Diet Adherence Score, which is a 16-point questionnaire that asks people about specific components of a Mediterranean diet. And a score of 8 or greater is regarded as good adherence to a Mediterranean diet. So before we started, we said that what we would say is success is that if 80% of the people on a Mediterranean diet could get a score of at least 8. And that's the pink, and we at weeks 6, 8, over 80% of the people on the Mediterranean diet did have a MEDAS score of over 8. At week 12, which was that last week of the study, we just it was about 78%, so just under our defined cutoff. Whereas the people on the standard USDA guidelines diet, we did not reach at any point during the intervention over 80% of them getting a score of at least 8. So this told us that by giving people a Mediterranean diet counseling, they were able to change their diet more towards a Mediterranean diet eating style. We also asked their MPN symptom burden with the MPN SAF, and again, I want to say that this is simply for observation, not to really make any claims. And each of the bars here is a person, and there's 4 different graphs at each week during the intervention time, and it's compared to their baseline score. So the ones going down mean that their symptoms got better. Lines going up means that their symptoms got worse. And interestingly, it appears it appears that any type of dietitian counseling can improve some people's symptom score. As you notice that there are some blacks going down. However, with the Mediterranean diet, we did observe that a higher percentage of that group did have a reduction in their symptom burden. And other things that we measured in the study, what we would call exploratory endpoints, meaning we wanted to gather data, but we really are not, would say, powered, have enough patients to really make any specific claims. We measured blood counts, measured cholesterol, high sensitivity CRP, inflammatory proteins in the blood, and then also the gut microbiome. So this is what data from people's inflammatory cytokines look like, and as you can see, stuff is all over the place. So it's difficult to, without a large number of patients, to really make any conclusions about how an intervention would reduce inflammatory cytokines. So each of the lines is a person, and that's over time. And as you can see, each person is quite different. But this was simply an observation and helping us to determine the number of patients that we would need in subsequent studies in order to really scientifically ask the question if a specific intervention does really reduce inflammatory cytokines. But just wanted to show this as a visual, just to show what data from inflammatory cytokines looks like. And we also gathered 24-hour diet recalls with a program that was developed by the National Institutes of Health called an ASA24, which is an online assessment. And so this is quite a laborious process for people to report. They ask about every single thing somebody ate during 24 hours, which you can imagine is not something really that's fun to do. With excruciating detail, need to report what you ate. But it gets really good data about calories, specific nutrients, all different specific vitamins, fiber that somebody ate over the past 24 hours. So one could ask, we specifically wanted to look at fiber because a Mediterranean diet is supposed to be naturally high in fiber, as well as because of an interest in the role of fiber, high fiber diets in reduction of inflammation. And both with the males and females, we found that the people who are on the Mediterranean diet, they tended to have increased fiber intake compared to the people on the USDA standard guidelines for Americans, which is not unexpected given that a Mediterranean diet is a naturally high fiber diet. We also wanted to look at the gut microbiome. There is a lot of emerging information about the role of the microbiome in disease and in health, and really nothing had been evaluated about the microbiome in patients with a myeloproliferative neoplasm. Prior to this diet study, we had looked at in a small study just at baseline of 30 MPN patients and 30 normal controls, just to see if there were any big differences between the MPN patients and normal controls. And interestingly, in that study, we did find, although didn't find necessarily significant differences between MPN and normal controls, did find some differences between myelofibrosis versus the PV and ET patients. In this study, we wanted to know how a Mediterranean diet might influence the microbiome in MPN patients. So with this, we collected 4 longitudinal samples from the people on the diet, 1 time before the diet, 2 times during the diet, and then a 4th time after they had completed the diet. And so the hypothesis would be that changing the microbiome in the intestine through an anti-inflammatory diet might lead to a more healthy microbiome and reduce inflammation. And interestingly, at baseline, we found the exact same trends that we did in our previous microbiome study in MPN, found that the microbiomes of myelofibrosis patients are less rich, meaning that they have fewer types of bacteria in their gut, and are less even, meaning that they have sort of spikes in particular types of bacteria as opposed to just a sort of a more even compilation of bacteria in their diet or in their gut. And so this was nice for us to see that in two totally separate studies, we really came to the same conclusion. And one could potentially conclude that with myelofibrosis patients, since they're a more severe form of myelofibrosis, and those patients also do tend to have more inflammation, that this is also reflected in their microbiome, that it appears to be more abnormal than the ET and PV patients. And then changes in the microbiome with diet. Again, this was a very small study, and because, as you can see, each one of these things is a person, and each little column is over time. And visually, you can see that each person's microbiome is very unique. So from person to person, our microbiomes are very different. And so it's very difficult to really dissect out particular impacts of things like a disease or a diet. But just for visualization, wanted to show that the biggest difference is an individual to individual difference. And at least with this small number of patients, we were not able to tease out significant impact of the diet on the microbiome. However, this was not in any way unexpected. And then the second diet intervention that we did was an e-intervention. Basically, we wanted to ask, can we do the same diet counseling and just do it over Zoom, which was very timely for COVID. And so we recruited patients online and did Zoom counseling, and then sent them kits for saliva collection. And so here it was a feasibility study as well. And this is for the saliva collection. We chose to use what's called an oral mucosal transudate. People stick this little pad next to their teeth, and it's supposed to get like a plasma sample. And in here we wanted to see, basically, if we're doing things online, are people actually going to comply with this? So amazingly, people were able to do 112 days straight of MPN SAF scores simply by us emailing them, as well as, and we also, interestingly, saw that in the people with a Mediterranean diet seemed to answer more surveys. This is a little bit of a stretch where we thought, well, maybe that means they're a little more happy with their diet if they're completing more surveys. We also looked at their change in the MPN TSS, and again, not powered to look at any differences, but just to observe that people on honestly both diets did have an improvement in their symptom burden. And then also completion of diet surveys and dietitian visits. They were able to complete their 16-point questionnaires, and not unexpectedly the ASA 24s, which probably take about a half an hour to do each, had lower completion rates. But everybody attended their dietitian visit, which I guess if you're getting a free dietitian visit, then that's probably an incentive to actually do it. So our next steps, now those two first studies allowed us to gather data to really design a much larger study where we can really ask, does a diet change symptoms? Does it change inflammatory proteins in MPN patients? So that's what we're doing. Also, although just a standard Mediterranean diet was a very reasonable place to start, we'd like to potentially alter the diet curriculum that's really tailored towards an MPN patient population, potentially focusing on improvement in the gut health with high fiber and potentially fermented foods. And so the acknowledgements. The first diet study was performed by a graduate student in my lab, Laura Mendez, who is an MD from Mexico and came to UC Irvine for her MD and now is back in Mexico. Andy Odegaard at my institution, who's a nutrition, he studies nutrition in particular in people with diabetes, and Helen and Jenny, who were undergrads in my lab and now are in medical school. Katrina Whiteson is an investigator at my institution who focuses on the microbiome. And then instrumental in the development of these studies, like to thank Robin Scherber and Ruben for really insightful discussions, as well as ongoing discussions with the MPN Quality of Life group as where we should go with future studies. So thank you.